oftentimes the several different shock states that we're going to talk about today. That's the bread and butter in medical ICU, and I love it. It's like one of my favorite things to talk about. So I know, just like anybody, right, that you guys are what's called test hungover. I know that, right? And I know you had 2 soft chalks that you had to turn in modules. You had your test, which was 3 modules. So that was a lot. So I understand that. I get that. Okay. But in order for us not to all just wither onto the floor and die, we all need to band together and try our best to get through this today. Okay. So I, of course, never expect you guys to know everything, right? That's why we're taking the time to go over this. This is why I'm lecturing, okay? However, this is a time to have your Nearpod and then in a different window, your soft talk module, your textbook, whatever can help you get through. That way, as a team, we can get through this today, okay? So, let us begin. Shock states, perfusion and peril. Yes, I did coin that term. Kind of clever, okay? Here's some objectives. You can take the time later to read those, okay? They're good for when you study, to guide your studying. Okay, so when we talk about shock, right, we are talking about, how I think about it is it's a cellular disease, okay? Now, we are going to talk about the over umbrella, the generalization of shock, and then as time goes on today, we'll dive into the more specifics of the specific types of shock you will encounter, okay? So, when you think of shock and you think of this cellular disease, okay, essentially at the cellular level, perfusion is not occurring, okay? That's like the general down and dirty of it, okay? At the cellular level, perfusion is not occurring for whatever reason, okay? And oftentimes, right, when we talk about the specific shocks, we can help identify, well, the perfusion at the cellular level is not happening because of A and B, right? But this, I'm just talking about the generality, okay? The general stages of shock and the general umbrella of shock. Okay, so when we talk about the stages, there's 3 different stages. The first one is compensatory, okay? Second one is progressive, and then the third is irreversible. So when we're talking about the compensatory stage of shock, okay, how is your patient going to present? How do you know they're in the compensatory stage of shock? So this is shock, the general umbrella, okay? So at the cell, I can switch to this. No O2, okay? Whether it's a delivery problem, or like an uptake problem. So I'm just talking generally, okay? As we dive into the specifics of shock, we'll be able to help identify the very specific symptomology associated with each of those shocks, okay? Actually, I think this is probably a better way to do it.
I was like a question today, and it's not me.
Okay, so again, shock is a cellular disease, right? Something is hindering the delivery of, or the demand is too great for O2. So we are not getting perfusion, blood and oxygen, right, to the cells. We need that in order to live, right? We need that in order to have perfusion of everything, okay? So when you are in the compensatory stage of shock, this is oftentimes the stage where people are at their house, right? Oftentimes this is before they come in to the hospital, okay? Or, now who wants to work med-surg PCU? Okay, maybe ED, okay? So these are the people that you will see people in compensatory stage of shock. Or, like I said, they've been at their house chilling and they think everything's okay and it's actually not okay, all right? So in the compensatory stage of shock, let's see, we have tachycardia, yes. Now this isn't necessarily, that's like the main thing that I see is tachycardia, is this isn't, you know, where the patient's tacking out in the 140s, 150s. This is where maybe they have been 90 sinus rhythm, 80s to 90s, and now they're getting to 105, 102, 110, okay? This is where their body is saying something is wrong. Something is wrong, something is off. Let me kick in those compensatory mechanisms, right, to help kind of solve the issue, okay? Now the tachycardia that we talk about, and I can talk about the pathophysiology. You know that I love pathophysiology, but that's from your sympathetic nervous system kicking in, right? Where they're saying something's wrong, I feel like I need to help, right? We're not getting oxygen at the cellular level, so I'm gonna become a little bit more tachycardic. Again, maybe not that 120s, 130s, but just a little bit, okay? And then again, remember, right? Going back to the very first thing, right? Where you're like, Professor Blur, why are we going over hemodynamics? I hate hemodynamics. But remember, your cardiac output, which is the driver for this O2, for your perfusion, right? Remember, what's the formula? Cardiac output? Heart rate times stroke volume, right? So this is where your heart rate's like, yo, I will help you, okay? Because something is happening where the cardiac output is not doing its job. It's not getting to where it needs to be, okay? The cells are suffering. Okay, so I see a lot of tachycardia. This is also when we see not so much, but a little tachypnea, okay, where maybe their respirations have been in the 20s and now low 20s, and now you see them 28, 30, okay? They become a little bit more tachypnic, right? Because again, make it make sense, right? Make the pathophysiology make sense. Something is happening where at the cellular level there's no O2. So your body is compensating, right? It's helping with the heart rate to move the blood, and then we are breathing a little bit faster. Your patient's breathing a little bit faster to hopefully get in a little bit more O2. Does that make sense? So they're gonna be probably a little bit more tachypnic, okay? Again, not those 40-50, breathing times 40-50, but again, just that slight uptick. So you can see the theme here, right, guys, is that there's slight changes. This is where your assessment skills are king, okay? Whether you're in the ED, you're in med-surg, you are in PCU, it is your job to notice these changes and to have a high suspicion, right? We're all detectives, right? Everybody's favorite show now is Law & Order. You all are watching it on your days off, right? Because you're learning to be detectives. You're learning to say, hey, this isn't how it was yesterday. This isn't how it was a couple of hours ago. There's some sort of change happening, okay? So the other thing that we can say is that, and I think someone put it in here, yes, good, oliguria, okay? So now we have some conservation of urine, okay? That's where your RAS, okay? You're like, what is all this pathophysiology? But it's so fun, right? Renin, aldosterone, or angiotensin aldosterone is kicking in, right? Is where there's a change. So I'm gonna try to hold on to fluid to compensate for it, okay? Because again, look at the formula, right? Make it make sense. Stroke volume, right? So we need something, right, to say, hey, something's happening. Something's happening where the delivery or maybe the demand's too great and we're not getting that O2 at the cellular level. So I need to manipulate maybe the stroke volume to ensure I have volume, okay, with whatever is going on, okay? And so we are not gonna pee as much, okay? Maybe your patient was peeing 100 an hour. You're like, yes, your output, check, stellar, right? And then you notice it drops off. Maybe it's 30, maybe it's 25, maybe it's 20, okay? So you see that change, Now, the most important thing to note in this stage is that the blood pressure is normal, okay? I'm gonna say that again. The blood pressure is normal, okay? So again, make it make sense, right? This is the compensation stage, meaning that the SNS, the RAS, all of the things that your patient's body is doing right? It's maintaining it because they've noticed something's off and they're like, yo, we got you. We got to maintain this because we need that perfusion at the cellular level, okay? And so blood pressure's maintained, okay? But you will see in terms of your patient, maybe they're a little bit more anxious. Maybe they're a little bit more restless. They can't get comfortable in the bed. Okay, so you see how there's these slight changes that happen, and then again, their body is compensating. The problem, right? The problem is that if we don't fix the issue that's driving this shock, this cellular disease, if you will, then they're gonna eventually, those compensation mechanisms aren't gonna work anymore. They're gonna run out. Okay, does that make sense? Okay. Questions about this? Questions about how the patient will present? Again, this is where your assessment is so important, you guys, to be able to notice these slight changes, okay? So now, the compensation stage is over. Yes?
I have a question actually.
Yes.
So compensation is first when are we not doing initial, or is that like the compensation?
Well, when you say,
The stages.
so initial and compensation are kind of the same.
The same one.
Yeah, exactly. It's like one and same name, essentially.
Just ask, because I saw like a picture that was like, one was the initial and two was compensatory, so just wanted to.
Are you talking about in the soft chalk?
No, somewhere else.
Oh, okay. Is this chat GPT? You can, okay, so you can be honest. Okay, so I think you make a good point, and I'm not picking on you by any means, okay? But I think it's so important. Okay, Chat GPT. I'm not gonna lie, I'm a novice with it, you guys. I've just recently started to even understand like what it is and what it can do. Okay, sure, there's definitely uses for sure, 100%, absolutely. But be careful when you use it. Okay, be careful when you use it, because you could run into things like this, where they are differentiating between they're saying that essentially there's 4 stages, which I don't know if I totally agree with. Okay, I can maybe say that the initial and compensatory stage is maybe the same thing, but oftentimes what I would just be careful with the resources. I think that there's definitely uses for it, but make sure you're comparing it to these evidence-based resources. Does that make sense? Okay. And I think that it's great. Like, I think there's definitely good uses for it. Like when I did your lines thing, that helped me generate it. And then I changed things because I had to go through and make sure it was accurate. So I think that there's definitely uses for it, but just be cautious, if you will. Okay. Of course, absolutely. Okay. So first stage. Okay, let's write that. So first stage, right, is we have the compensation, which we talked about. So there's some sort of initial result, and now we're on compensation. And the key factor to remember, right, is that the blood pressure is maintained. Okay. And usually that's per the sympathetic nervous system and then the rest, to name a few, okay, if you want to get down and dirty for the pathophys, okay? But now we've moved on and the patient is kind of teetering off that cliff right now. They're not totally off the cliff, but they're heading towards the cliff, okay? So head to toe, how will your patient present? I want you to be thinking cardiac, or neuro, okay, I should have put it really head to toe, but neuro, cardiac, hepatic, GI, renal, okay? Now when we get to each shock, there will be unique symptomology that I will point out that you will need to know, okay? But we are talking, again, the umbrella of shock, the general umbrella, okay? Okay, so let's think about this head to toe, right? You have the patient, they're, a rapid response was called, okay? They were on your unit or, someone's unit for progressive care, and they started to show signs of changes, vital sign changes. They're a little bit more tachy, they're a little bit more tachypnic, right? When the rapid response was called, their blood pressure was normal, okay? But now they're in the ICU, they've arrived to you, and now we are looking at the progressive stage, and we are hypotensive, okay? Okay, so neurologically, how are they going to present? I see confused, yes. Confused, altered level of consciousness. Now, when I say altered level of consciousness, what does that mean to you guys?
A little confused, a little restless.
Okay.
A little out of there. Like when you wake up and you're like.
Okay. So you're totally on the right track. Absolutely. Those are definitely components to it. But I think it's interesting because I feel like people use these terms very blatantly, where they're like, ALC, they were altered, level of consciousness, ALC. Why are they coming in? Oh, altered, okay? So your level of consciousness, when you get down to it, right, is how awake and alert you are, okay? Yes, I think the components of being confused is certainly there, but when you say altered level of consciousness is how awake, alert you are. And so these are the people that are going to be lethargic, okay? Lethargic. So you talked about maybe that first initial stage, Scarlett, of when you wake up, but they don't really wake up. They're still very lethargic, or they might even be obtunded or stuporous, okay? We'll get down and dirty for the terms when we get to neuro, but I think it's important for everyone to understand, because I think this term gets thrown out all the time. I see it even on my floor, where people throw things out, and I'm like, but do you actually know what it is you're saying, okay? So when you have altered level of consciousness, they are not going to be the ones that are awake and alert, right? When you go in and you say, hi, I'm Chelsea, I'm your nurse, they're going to be laying there with their eyes closed. Where you're going to go in and say, Mr. Smith, and maybe either he'll have to be aroused by voice or even maybe touch, okay? And then when you do arouse him, he might open his eyes for a little bit, but then he might shut them, okay? When you ask him questions, he might be very slow to answer or maybe not answer at all, okay? Maybe he'll just have some garbled sounds, okay? So again, let's make it make sense, right? I know you guys are like, I'm so tired of hearing that term, but I think it's important to understand the full picture, okay? And so we can say, right, remember, after the cellular level, O2 delivery or consumption is too great, so the cells aren't getting perfusion. I'm talking about the brain cells, okay? So we're talking about cells everywhere in the body, which is why they are altered. Why maybe their level of consciousness is not amazing, why they are confused, okay? Does that make sense? So we go, this is the, the head, okay? So we know that something is off, Okay, we're questioning whether they're able to protect their airway. What do I mean when I say that? Protect their airway. What'd you say? Seizure? I mean, they could be at risk for seizure. Sure, absolutely. What'd you say?
Aspirating, not able to swallow.
Okay, perfect. So aspiration is a huge risk. So when I say something like they can't protect their airway, that means that if I were to say, Mr. Smith, cough, he doesn't know what that is. He doesn't understand how to cough, okay? Hayden said swallowing, right? So maybe swallowing is hindering, okay? So again, it's our natural, human situation to make secretions in our mouth, okay? And so you know, like, right, you've been there and you're like, you're clearing your throat, maybe you're coughing, right? You are able to clear your airway, okay? These people that are altered and confused cannot clear their airway, okay? They cannot clear their airway. They are obtended or stuporous. We'll go over those terms because I know you're probably like, what does that mean? And so again, they are not with it, okay? When I tell them cough, they don't know what the cough, they don't know what that means, okay? When I stick a yonker down their throat, they don't choke, okay? I know that sounds aggressive. I don't choke my patients purposefully, but it is important to assess, like, are they gonna cough? Are they gonna gag, okay? And sometimes when we have this kind of situation when they're altered, they don't, okay? So, again, right, they're not able to protect their airway. Now I'm thinking maybe they need to be intubated, okay? In terms of vital signs, they are worsening tachycardic, right? So we talked about how their tachycardia is low in hundreds. Now we're seeing 120s, 130s, 140s, okay? Because again, remember, they were compensating. They were compensating, and your body is gonna try to compensate until they fall off the cliff. So again, we are trying to maintain the perfusion of this cardiac output, but something's happening, so your heart's like, let me work harder. Let me pump faster, right? To maintain this, but again, that's actually worsening the situation. So we are more profoundly tachycardic. We're 120s, 130s, 140s, okay? We are more tachypnic, right? Our respiratory rate is now in the 40s, right? Because again, the problem is we don't have O2 at the cellular level, and so your body's like, whoa, things are going badly. We need to figure this out, okay? Now, what do you think the skin is doing? I didn't put that on there, but the skin, remember, is your largest organ, okay? So what do you think is happening with your skin?
It's not getting blood flow, so it's gonna feel cold.
Okay, cold, pale, okay, clammy, right? Maybe it's mottled. We talked about that term, right? It looks like a leopard. What do you think the cap refill is going to be? Greater than 3. It's probably going to be like, I don't know, 6 or 10 or something, okay? It's not going to be good. Because remember, skin's your largest organ, and at that point, right, the progressive stage, blood flow and perfusion is definitely not going there, okay? Your body's trying to shunt the blood to the most important organs, but we're kind of failing. We're failing, how do we know? Because we're confused and we have an altered level of consciousness, okay? And so, tachycardia, tachypnea, what do you think about our metabolic state? What do you think about our metabolic state? Acidosis, yes, exactly. What type of acidosis? Is it respiratory or a metabolic? Careful. So if you were thinking about it, right? We talked about that our respiratory rate has gone up profoundly, right? So if you are tachypnic, do you think that the acidosis is respiratory in nature? No. Why? Why is it not respiratory so think about your ABGs. I know you're like, Professor Blur, I haven't had my bagel yet. I need to drink more coffee. It's only 9:45. I'm hungover from yesterday's test. So think about if you are breathing fast, right? Think about if you're breathing fast. What are you doing to that CO2? You're blowing off a lot of CO2. So what is that going to do to your CO2 level? It's going to decrease it, right? Is that what you said? Yeah, decrease it, okay? So it's probably going to be very low. Normal is what? 35 to 45. So let's say that it's going to be 20. Okay, 20. Now, we haven't gotten there, but that was our next thing, renal. Okay? Your kidneys are taking a hit, right? Your kidneys are not being perfused. So I'm gonna bridge the things here. Don't worry. We're not losing out on metabolic acidosis. So your kidneys are not working. Your urine output is what? It was oliguric. Now what do you think it is? Even more oliguric / maybe we're also anuric, right? Maybe we're not making a lot of urine. What is my creatinine and BUN going to be? Super elevated, exactly. Okay, so one of the jobs of the kidney is to make bicarb. Is that not correct? So one of the things that we are hopefully doing, right, is not doing is the bicarb. We don't have bicarb. So we are losing bicarb because our kidneys are not working. So we cannot offset the acidosis this is happening, okay? So again, we're looking at metabolic acidosis. Now, let's take it a step further, right? So who goes to the gym, works out? You don't have to raise your hand, but people do that, right? People, maybe before nursing school you did that, right? So when you go to the gym, right? Like yesterday I worked out and my legs are quite sore. I went to sit in my car today and I was like, oh, it hurts a little bit. When I went to the bathroom, it hurts a little bit, right? I'm sore, okay? So what happened was I have lactic acid buildup, right? Because my cells yesterday, I used a lot of the oxygen in my muscles when I was working out, and so I went from aerobic, which is like oxygen metabolism, to anaerobic, okay? When you have anaerobic metabolism being utilized, whatever, right? I had it utilized when I was working out. You have lactic acid, okay? Keyword acid buildup, okay? So that is another driver of that metabolic acidosis that you will see, okay? Does that make sense? Yes? Okay. Yeah, everybody's like, okay, gotta drink more coffee. I also need to drink more coffee. Okay.
For the lactic acid, is
Yeah.
it coming in shock? Is it coming because the lungs and the heart are all trying to like work really hard, or where would the
Are
lactic
you
acid
asking
build
where
up?
the lactic acid buildup is happening?
Or
or
like,
why?
where is it coming from?
Sure. Great question. So, again, if we look at my little fabulous diagram here, is that we either our delivery's messed up or the demand is too great for the cells to have a O2 delivery, okay? And so your cells have to have some sort of metabolism, okay? We hope and wish that it's always aerobic, which is O2 driven, okay? But now, when you are missing this, what happens is you have anaerobic metabolism. And that is what the lactic acid buildup happens, okay? So yes, your heart and your lungs are working harder because they're like, what the heck? Where's the O2? I'm trying to deliver it and it's not happening, right? But why we have that metabolic acidosis, why we have that buildup is because we have lactic acid buildup because we are in an anaerobic metabolism. Yes?
So that begins in stage 2, right?
This is stage 2. Yes, exactly. Okay. So all the compensation mechanisms have failed now, and we are seeing the patient have this total lack of perfusion. Hence, why the organs are being affected. Okay. So we talked about kidneys. Let's talk about liver really quick. You know, liver is one of my favorite organs, right? It has many jobs. Okay. So if you think about your liver is affected, right? Your liver is not getting the perfusion that it needs. How will it affect your patient? I don't see anybody that talks about it, but it's so important because you have to anticipate these kinds of things, okay? So let's think back. I know you're like, oh, anatomy and physiology, this is too much for me this early in the morning, but think about what some of the liver's jobs, okay? So what is the liver? What are some of the jobs that the liver does? Okay, it metabolizes drugs, sure. Okay, the filter is the kidneys, but it metabolizes drugs, the liver. So you could think that anything we give the patient at this point, They're gonna not be able to probably metabolize very well. What else? Coagulation, yes. So the liver is in charge of making clotting factors, okay? So that's gonna affect the patient's bleeding, right? They're gonna be at higher risk for bleeding. Their INR is gonna be high, their PTT is gonna be high. Not because we gave them any medicine, it's because their liver is not working. Okay, so they're gonna be at high risk for bleeding. Excellent. Excuse me. Now, within those clottings, it also, the liver, remember we talked about this before, I know you're probably like 500 years ago, but they make thrombin. Thrombin makes thrombocytes, also known as platelets, okay? Platelets are necessary for clotting, right? We need platelets. So we know that their platelets might be affected, right? What about sugars? What is the liver in charge of in terms of sugars? Blood sugars. Anybody remember? The liver is, pancreas is insulin. Glucogenesis, exactly, excellent. So it makes the sugar, makes the glucose, okay? So when you have someone that is in liver failure due to lack of perfusion, right, you're gonna see a drop in their sugars. You're gonna check their sugar and you're gonna be like, oh, it's 50. Huh, that's weird. I didn't give them any insulin. Well, that's their liver because their liver is failing, so there's no sugar happening. There's no glucose. Does that make sense? So again, we see in each of these things that are happening, we have the organs are failing and that's affecting the patient, okay? Now, last but not least, certainly, GI. How is the patient, do you think, going to be affected? How is their GI tract going to be affected? Slow, constipated, yes, 100%. So do you think that they're going to be having normal bowel movements? Do you think that their bowel sounds are going to be active, you can hear it, things are great? Absolutely not, okay? So things are going to lead probably to an ileus, right? Things are going to be slowing down, okay? And we know that when things slow down, things get clogged there, the high risk of maybe a perforation can happen. Okay, we don't want a perforation to happen, right? So again, the hypoperfusion in the GI is very concerning, okay? People actually die from dead gut way more often than other things, interestingly enough, okay? So hypoperfusion, no perfusion to the gut is a big deal, okay? So we have this, gosh, things are just not going well for this patient. I'm very sad, okay? So this is a patient, okay, on a ventilator with renal and liver failure. Okay, so right out the gate, I'm giving you this situation. So their kidneys are failing, the liver's failing. I started, because I worked overnight. Never work overnight, that sounds terrible. We started CRT, continuous renal replacement therapy. So it's like dialysis, but the difference is that it goes 24/7, okay, it never stops. The fluid shifts are much more gradual. They're very, very gradual. So how to think about it is that in hemodialysis, right, you will hear the dialysis nurse say, in a 3-hour period, I took off 3 liters. So essentially, per hour, we're taking off a liter. That's a lot, right? Think of a liter back. That's how I think about it. In this instance, with the continuous renal replacement, I might not be taking any fluid off. I might just be cleaning their blood, okay? Or if I am, it's 10 cc's an hour or 25 cc's an hour, okay? Think about a 10 cc syringe, very different than a liter bag, right? So we're on continuous, we're on CRT, so much easier to say. Patient sedation have been off for 24 hours and it's now the patient's lacking a substantial neuroexam. What does that mean? So they were on propofol and fentanyl, and both of those things are off. We haven't had any sort of propofol and fentanyl for 24 hours. And they're lacking of substantial neuroexam. What does that mean?
That they're not aroused or...
They're not arousable. Okay, perfect. So they're intubated, right? We said right there that they have a ventilator on, okay? And we are off sedation, off pain medicine, and essentially their GCS is 3. They're not waking up. They're unresponsive, okay? I go in, I try to say their name, Mr. Smith, no response, okay? I do some sort of noxious stimuli, right? I do a painful stimuli to get a response, nothing, okay? So that's what that means. When it says lacking a substantial neuroexam, they're not waking up, okay? So if you had to conjecture about what's happening with this patient, what organ can we say is really affected now?
Brain.
The brain, right? Excellent, good job. So we can say that the brain. So far, we are on a ventilator. So what organ is that? The lungs. Okay, so we got the lungs. Lungs, sad for us. Renal, kidneys, liver. Okay, we know that the kidneys are also suffering because we're on CRT. That's a big clue. Okay, and then our brain, because we're off of any sort of sedation or analgesia. Okay, on 4 pressors and still progressively hypotensive. So name them out. What drips am I on? I'm on 4. Four vasopressors. So what am I on? Maybe not dopamine. Maybe not dopamine. I hate dopamine. So oftentimes in my scenarios, there's no dopamine. So dopamine is very specific, right? We kind of talked about it a little bit. Dopamine is that thing where you have someone that's hypotensive and bradycardic. This person is not bradycardic yet. They're still tacky, okay? So you're right, all the other ones. So Levophed, norepinephrine, right? Phenylephrine, or neosynephrine, okay? Vasopressin, okay? And then the 4th one, the big daddy is what? Who's the big daddy? Epinephrine, okay? Remember, why we say that is because you give epinephrine when people are dead, okay? So we have 4. Essentially, we're kind of pericoding them right now, essentially, right? We got 4 vasopressors, and we're still progressively hypotensive. So, huh?
Are we just doing it? Are they alive?
I mean, that's a great question, right? I mean, this happens all the time, guys, right? This happens all the time where, are they really alive? I mean, they are. They have a blood pressure and their heart's pumping,
But do they have a blood pressure because you have four pressors?
and they're progressively hypotensive. So, what ideally would we like our MAP to be? 65. In this situation, we're probably 50 or 45. Okay, so we are certainly heading towards not being compatible with lead, 100%. Okay, we're not quite there yet, but we probably are heading that direction. Yes.
Which ones did you say were the big 4? Norepinephrine, vasopressors.
Norepinephrine, vasopressin, phenylephrine, and then epinephrine.
Would it be like in that order, preferably?
Yes, yes, yes. Again, I'm going off of me and my unit and what I do. There could be people that love dopamine. I'm just not a fan of them because I think that it's specific and oftentimes we don't meet that criteria. Okay. Okay. So let's look at our ABG. Okay. So pH of 7.1. What are we looking at? Acidosis. I hear acidosis. So a normal pH is what? Perfect. Okay, so we are very down, right? Let's do it over here. See, isn't it nice to have a whiteboard? It's not that I didn't love the library, because I love libraries, but no whiteboard, and that was sad for us. Okay, so acidosis, right? Right away we can say that. Now, what's the driver here? So CO2 of 35, high, low, or normal?
Normal, but on the low end.
Well, normal, but it is heading towards the abnormal side, right? And then bicarb, 5. That's unfortunate. Bicarb of 5. So what is that? It's low, right? So again, Rome, okay? That's how I do my ABGs. If you don't do that and I'm confusing you, I'm so sorry. But metabolic equal, right? So both the arrows are pointing down. I know that what's driving this acid-base issue is the metabolic, okay? And then PaO2 of 59. What do we think about that? It's also bueno, right? 59. What would I love it to be? Above 80, right? Above 80. So we are probably on 100% on the ventilator, and I'm still hypoxic. Okay. So this being said, what stage of shock are we? The end. Yes, we have moved to the irreversible stage, 100%. Okay. So this is, like Alicia said, survival is unlikely. Okay, we're doing all of the things. Now, this situation is hard for people. Okay, because they're gonna think, well, but you're on everything. You can fix him. Okay, but we need to understand that communication with the family is going to be very key in these kinds of situations. Right, their ability to listen is hindered. Okay, you are probably going to be repeating yourself a lot. Please have some grace with that, okay? Yes, I know it's annoying. I know, I've been there where I'm like, oh my God, I just said that. Why aren't you listening? But when they're emotionally distraught, their ability to take in information is very, very difficult, okay? Oftentimes what I do is I help with the visual, okay? I help with the visual. So when the family comes in, I talk about all of the machines. Okay, so just like we talked about, right, the ventilator. I say this machine right here is doing the work of their lungs, okay? Our CRT machines are big, and they're either green or black. And I say this big machine right here is doing the work of the kidneys, okay? And I tell them they're on no sleeping medicine. They're on no sleeping medicine, no pain medicine, and they're not waking up, okay? They're not waking up. And then I look at all the drips that I'm on, because I'm probably on quite a few, okay? And I say, this is what's helping keep their blood pressure, what the number is, and we're not even where we need to be. We're not at our goal. But all of these medications is what's helping maintain what we have up there, a MAP of 50, which is terrible, okay? Now, oftentimes I don't tell them about numbers because they perseverate on that, and that's kind of a dangerous thing to go down. But irregardless, at this point, you need to talk to your physician and have them come to the bedside, okay? You can start that conversation with explaining how sick they are, but the physician needs to have a code status talk, okay? Because at this point, when the patient is maxed out on all of these drips, because I can guarantee they're gonna be maxed out, we're at our limits or above the limits, okay? Then we need to be talking about maybe making the patient a DNR, okay? Now, DNR, I had this situation actually with my own family, okay? DNR does not necessarily mean to stop everything, okay? DNR is do not resuscitate. So what that means is that if this patient were to go pulseless, we would not do compressions, okay? We essentially are giving them all of the medication that we would give them in a code. We are. Yes, the concentrations are a little bit different, but we are. We really pretty much are. So if the patient heart were to stop and we were to do compressions, the chance of us being able to get them back to ROSC, return of spontaneous circulation, would be very, very nil. It would not happen. We would be causing more trauma and pain than is necessary, okay? Now, it could be that the patient's family will understand that this is not compatible with life and maybe make them comfort care. Now, comfort care is different. Comfort care is where we will stop everything and they will die naturally, okay? We'll extubate them, take them off the breathing or the ventilator. We will stop CRT. We're gonna stop all those drips, okay? Does that make sense? Do you understand the difference? Okay, but that's hard for people, okay? That's very, very hard for people because they don't want to make that decision, right? Because you always have that, well, what if, right? What if it's just one more day and they get better, right? When someone is in this irreversible shock with all of those organs, when we have progressed to MODS, multiple organ dysfunction syndrome, the chance of being able to come back from that, especially if you are talking about someone that's a little bit older, they have comorbidities, is very, very poor. Okay, does that make sense? So you want to make sure that you give the opportunity for the family to spend time with them, talk to them, okay? Hold their hand, okay? you know, we have a strict rule in our ICU for 2. I oftentimes get in trouble, but I let more people come in because this might be the last time that they see their family member, okay? And then interdisciplinary approach, this is where you are going to have the help of the physicians, right? We, the physicians, maybe palliative care can come in. They can help kind of support the family. Chaplain is also someone that's great to come in and help, okay? If the family wants that kind of support, okay? Does that make sense about this? Okay, so when we get to irreversible, oftentimes we are heading towards the patient expiring, okay? Okay, so let's put my third shock here and irreversible. Am I spelling that right or no? Is that right?
Yeah.
Okay, we're off to the right start. Okay,
I give you the points for it.
what'd you say?
I give you the points for it.
Thank you, I appreciate it. Is it wrong? Oh, okay, I was like, I thought it was right.
Partial points.
I mean, the defibrillation, that was my favorite one. Oh, and rhythm. Rhythm's hard to spell too. Okay, questions about the umbrella of shock, the different stages. Questions about what's going on pathophys-wise, okay? Now, I know I would love to just spend all the time talking about pathophys, but I do think there's some merit in going over it because it helps you kind of figure out how the patient is going to present, okay? So there is some merit to that. Okay, let's do this one. So, patient presentation. Patient presents with the ED complaining of right thumb pain, okay? Progressive fatigue and shortness of breath on exertion. Lungs on auscultation reveals crackles throughout, okay? So if you could underline something, that would be something that you would want to underline. Crackles throughout, okay? Because this other stuff, right? Thumb pain, what the heck, who cares, right? Who cares about that? Progressive fatigue, shortness of breath on exertion, that's something to probably pay attention to, okay? Patient reports he has felt this way for a couple of days, so he's been battling this. Patient is diaphoretic and cool, okay? Vital signs, heart rate of 117, blood pressure 89/55 with a map of 59. Oh, sorry. Heart rate, what are we thinking? High, low, or normal? So we're a little tachycardic, okay? Blood pressure 89/55 with a map of 59. Slow, right? Do we love that map? No, we hate it. We'd love it to be higher than that, okay? Respiration of 32, high, low, or normal? It's high, perfect, okay? Temp of 36.8, normal thermic, okay? And then a SAT of 83% on room air. That's kind of low, okay? That is kind of low. So, in looking at this patient, right? Given this patient presentation, what do you suspect? What do you think is going on? And then what diagnostic tests do you anticipate? How can we figure out what is going on with this patient? So take some time. Again, nursing's a team sport, you guys. Feel free to discuss amongst your tables what you think is going on. Discussion is great. I love it.
And the diagnostics test. Professor, while we're discussing this, I have another question.
Sure, what's up?
It's like trickling from our last subject, but I think it also pertains to this.
Okay.
So if a patient's DNR, right, and they're in a lot of pain, and we want to give them like something for the pain, like morphine or something, but they're already like in the progressive stage, and their kidneys are trashed, and their respirations are trashed.
Yeah.
Would we, at what point do we give pain medication regardless of how it can negatively affect the patient?
When they're uncomfortable.
When they're uncomfortable. When do they become comfort care? When they're DNR or when they specify?
No, when they specify. Because remember, DNR and comfort care are not synonymous, not the same thing. DNR just means that if the patient's heart were to stop, we would not do compressions. We would not give them code medications, okay? But when they're in comfort care, your main goal with comfort care is pain control, to make them, again, not to sound silly, but to make them comfortable.
Yeah.
So it doesn't matter if their respirations are 5, you still give them morphine if they're in pain. Does that make sense? And you give them something like Tylenol or Advil, it's not gonna work,
Yeah.
right? That's not gonna help them. You're gonna be giving them fentanyl, morphine, Dilaudid, things like that. Because again, your main premise is that comfort care.
Yeah,
Okay.
I know that was like a question in the exam, and I got confused because on the soft shock it says we give pain medication to alleviate pain, not to like fasten death.
I mean, unfortunately, sometimes
It's inevitable.
it's
still
called
right
it's
there.
called a double effect, which again, your premise is pain medication, pain control, but we know that the side effect is lowering respiration. You're not doing it to lower your respiration. You're doing it to help the pain. Does that make sense?
Yeah.
But sometimes the side effect you can't
Do anything.
do anything about it. Yeah. And that's hard. It's hard for people to understand that. But again, your premise, your main goal is to make that patient comfortable.
Yeah.
Yeah.
The lactic acid. What? Maybe
It's DMT, no?
yeah.
The metabolic.
Yeah. And then the ABD is the same for the metabolic.
Or maybe there's like a specific test that you know what they do for lactic acid. Like how there's like troponin and DMT.
It just says lactic acid. Yeah. Diagnosing lactic acidosis. So that's hypoxia, shock. So I think when you said heart failure, you're looking at the cardiogenic specific.
It's just every time I hear echo in the lungs, I just think it gives me pain.
Yeah.
And how do we? Yeah. And then you said that he experienced it for a couple days, and he feels fatigue. And
You guys wanna talk about it? Yeah?
Yeah.
Okay. So, what do you suspect? So, if we were to go back, right, and look at some of the things that are happening. Okay, so we know that we're in some sort of shock. How do I know that? Because my blood pressure is low. Okay, my blood pressure is low. If you had to do the stage, it would be progressive, right? Maybe the beginning of progressive, but again, we know that it's progressive. Now, specific, right, is this weird right thumb pain. But the most important thing is the lungs and auscultation reveal crackles throughout, right? Patient is diaphoretic and cool. So if we wanted to think about, right, let's see, what do I have here? Okay, so if we had a chest x-ray, for example, why did I get a chest x-ray? Why do you think? Okay, so to see if your listening, your auscultation matches up with that, right? To match up with, does it look like the patient has pulmonary edema? Okay, so if we're looking at pulmonary edema, okay, let's see, second stage of doc, ABGs. Okay, so what would I anticipate my ABG to be? What do you think? How would I think that they would present ABG wise? Could be, but again, I think it's not like, we're not on any pressors yet. We're not on any vasopressors. They're hypotensive, but it's the beginning stages of this progressive. So they probably just went from compensation to progressive, where those compensation mechanisms probably just first went out, right? So the ABG is probably gonna tell us that they're hypoxic, right? That's the main thing, okay? Hard to say, respirations of 32, they probably will have some respiratory alkalosis. We probably haven't gone to that acidosis yet, okay? We're heading in that direction, but if I had to venture to guess, it would be respiratory alkalosis. Why? Because my respirations were 32. I'm breathing fast, okay? So my pH is going to I'm blowing off too much CO2. And then certainly we know with a room air sat of 83%, right, that we can know that we're gonna be hypoxic. Does that make sense? You're tracking? Okay, so now, let's see, CBC, what do you think that's gonna be? If you had to venture to get CBC, what do we think that's gonna be? Maybe the white count would be elevated, sure, because are you thinking infection?
Yes.
Okay, maybe, we're not sure, okay, but it could be, or it could not be. you know, if the patient was saying that he's progressively felt fatigued, probably not going to be drinking a lot, right? Maybe a little bit, could be dehydrated, okay? So maybe CBC, he might be a little hemoconcentrated is what we would say. Now, this is my EKG or ECG to identify any dysrhythmias, okay? And then BNP echo. Oh, interesting, okay? So what is a BNP going to tell me? Heart failure, okay? And then I'm just going to say 12 lead. I'll help whoever else said that. 12 lead. What is a 12 lead going to tell me? Okay. Perfect. So is this cardiac in nature, right? Is this cardiac in nature? So the big clue that we can think it, right, is that they have pulmonary edema. Why do they have pulmonary edema, right? And then on exertion, shortness of breath, okay? Weird right thumb pain, okay? Weird, what does that have to do with anything? And then did I tell you how old that patient was? Oh, sad I didn't. They're 85. So we have a geriatric. So someone like that is not going to be presenting like a normal person with some sort of coronary issue, right? Remember, geriatric people are atypical. They could be silent. He's kind of silent, right? So again, if we think about that very important clue of the pulmonary edema, right? Where is the pulmonary edema coming from? We could think that it's cardiac in nature, okay? So cardiac in nature, we're thinking cardiogenic shock, okay? Cardiogenic shock. Now I know these symptoms are weird, right? But this is how they present. So if you have cardiogenic shock, what do you anticipate for medical management? What do you anticipate for medical management? Pharmacological, what do you anticipate, what kind of drugs? And then nursing interventions, what do you think? Now, in looking at cardio, before you like start typing and discussing with your friends there. Now, for the cardiogenic shock, we know, right, that the pump is not pumping blood forward, right? Something is making the pump not work, okay? Now, the clue that I gave you is that pulmonary edema, right? It's backing up. It's causing that pulmonary edema, okay? Now, there's coronary causes and non-coronary causes with cardiogenic shock. Now, when I say coronary causes, what do you think that means? An MI, yes, an MI. Heart failure is what's resulting, but again, what's the cause of the heart failure, right? So what's the cause? So you said an MI, absolutely, okay. What else? What else do you think? What's another coronary cause?
Ventricle atrophy.
Yes, well, maybe not atrophy, but how about a rupture? That's a great one, right? A rupture of a ventricle. So again, you have to think about when you think about cardiogenic shock, the pump is not pumping effectively, okay? Something is wrong. Coronary means that they maybe had an MI, maybe there's a rupture of the ventricle, okay? Sometimes you can have what's called shock ventricle. My patient that I talked about a little bit ago, he was on bypass for too long, and essentially his heart kind of turned into a stone. It was significant shock ventricle. So he had to be cannulated for VA ECMO. He had significant cardiogenic shock, okay? So again, the pump is not working. Now, non-coronary, right? Non-coronary could be a myocardial contusion. They got in a car accident, the seatbelt hit them right in the sternum, and they have a big myocardial bruise. And that's making the heart not pump effectively, okay? Pericardial tamponade. That's a huge one, right? Oh my gosh, Professor Bloor, we're talking about things that we went over last week. Yeah, you better believe it. Things move forward, right? So remember that cardiac tamponade, you have pericarditis, you have too much fluid in that sac, right? And the heart cannot pump effectively. See the theme that I keep saying 500 times over and over and over again? Okay, so cardiogenic, right? Oh, it's gonna be a fail. I'm gonna die. So cardiogenic, right? If you had, this is how you guys should be studying. So number one is the heart cannot pump. Can't pump. So this is cardiogenic is the first type of shock. okay? So concept maps, very, very key when you're talking about these kinds of shock, okay? Now, what do you anticipate for medical management? Let's look. So we had a 12 lead. It was shown that he was having an MI, okay? I didn't see troponin on there, but we sent a troponin, it was positive, okay? The 12 lead said a STEMI, okay? Oh, I love it. Dobutamine, okay? If the heart can't pump, we need a drug that can help it pump more effectively. So we need a positive inotrope, okay? I love it. Now, be careful with diuretics, okay? Fluid management is really weird with cardiogenic shock. I know you guys want an A plus B equals C answer. I know you want the recipe. But you have to kind of figure out what's happening with your particular patient, and it's different for each. So fluid administration, I would say, is gradual. Diuretics, what's happening with diuretics? Why do I give someone diuretics? No, don't erase it. It's okay. Whoever said that. I'm not saying it's wrong. I'm just saying you have to be careful. That was very aggressive, you guys. Very aggressive. I'm not saying diuretics are wrong. They're not, okay? So much like decompensated, that was so funny. Much like decompensated heart failure, right? You're wanting to decrease that preload, right? Because the preload, that increased preload is what's causing that pulmonary edema and maybe probably peripheral edema, okay? And so you might see diuretics, but we know that diuretics are also going to lower someone's blood pressure, right? So you have to be careful. Okay, so you have to be careful because we know that the patient is in shock. Does that make sense? We know the patient's in shock, so you might need to give them a little bit of fluid. Now, are you slamming in 2 liters 999 with this particular patient?
No.
Absolutely not, because what is going to happen?
Overload.
You're going to overwork the heart. They're going to be in fluid overload. You're probably going to have to yes, you will drown them. They will not be able to breathe. They couldn't breathe before, now they really can't breathe, okay? So you could probably do some gradual fluid administration, okay? Gradual fluid administration where you're kind of filling the tank but slowly. So maybe you're going to do 500 cc's over 4 hours, okay? So again, it's this give and take where you might need to take a little fluid off, but you also might need to give a little, okay? Again, you're looking at your patient. When you're starting dobutamine, we know that there's vasodilator effects of dobutamine. We know that, right? That's how it works, is it's going to decrease the afterload. So when someone's in cardiogenic shock, you might be starting that dobutamine in addition to Levophed, okay? Because again, we need to make sure that we are raising up that MAP to a level, to a number that we like, greater than 65, okay? Does that make sense? Okay. So essentially, when you're talking about cardiogenic shock, we need to figure out what the cause is, okay? What is the cause of the heart that it's not being able to pump effectively, okay? The patient that I talked about, okay, he was 85, geriatric, he was presenting having an MI. Atypical symptoms, right? Atypical symptoms. I didn't say what, he was tachy, 117, but I didn't say what kind of rhythm he was in. But he probably was in some sort of dysrhythmia, whether it was AFib or what, okay? And so we sent that 12 lead, his troponin was elevated, okay? Now, when someone is in shock like this, am I gonna be starting someone on nitroglycerin? No, right? And so again, we're having to look at the patient, right? We know that he has progressed to cardiogenic shock, okay? So he's not a candidate at this point for nitroglycerin. Okay, I'm definitely going to start him on some O2. I can definitely give him an aspirin, but he needs to go to the cath lab, right, to have that PCI to fix it. But we know that the heart has already, the damage kind of is already done because we're not pumping effectively. We're in shock. Does that make sense? Do you understand how things have kind of changed a little bit? So what you're going to be administering to the patient changes, okay? So the name of the game is to help the heart pump more effectively, okay? Because we know that our delivery of O2 is not working because the heart's not working, right? So we need to optimize it somehow. So they're gonna be started on O2, we can give them aspirin, and then we probably could maybe give them some pain medicine, morphine, That's gonna help decrease preload, decrease myocardial oxygen demand, but we can't be starting nitro at this point, okay? I mean, it kind of works out because he's not complaining of chest pain, so we're kind of okay with that. But again, we need to fix the problem. The problem is that he has some valves that are blown out and some blockages, so he needs to go to the cath lab to have that fixed, okay? So again, when you look at cardiogenic shock, you need to fix the cause. What is the cause, okay? Fix the cause. We need to manage any sort of dysrhythmias, whether they're bradyarrhythmias or tachyarrhythmias. We need to manage them, right? All last week, what we talked about. You need to make sure that we support the reperfusion, right? So he's going to the cath lab to have reperfusion and all the things that entail after that, okay? Does that make sense? Okay, but with cardiogenic shock, the king here is that your BNP, brain natriuretic peptide, right? Because the ventricle is not working effectively, is going to be elevated. And you have to send those other heart type labs, right? Troponin, 12 lead, to diagnostically figure out, is it a coronary cause or is it not a coronary cause? Okay, does that make sense? Questions about this? Okay. Let's do some questions, then we'll take a break. Okay. So, a patient is being treated for cardiogenic shock. Which statement below best describes the condition? Select all that apply. Okay. So, oh, there's 4 questions. Oh, I forgot about that. Okay. So, patient will experience an increase in cardiac output due to an increase in preload and afterload. Okay. So right away, do we think that they are going to be having an increase in cardiac output? No, of course not, right? We know that that's the problem. We know that heart rate and stroke volume, this whole mechanism, the pump is not working. So cardiac output is going to be very low, okay? A patient with this condition will experience decreased cardiac output and decreased tissue perfusion. Yes, that is what's happening. The pump is not working, okay? This condition occurs because the heart has inadequate blood volume to pump, okay? No. What type of shock are we talking about with that? If you just had a guess. Hypovolemic, yes. So the volume, right? Big key thing, inadequate blood volume. Hypovolemic. See how those things go together, right? Okay. And then cardiogenic shock leads to pulmonary edema. You better believe it, okay? Better believe it, because the pump is not pumping forward, so things are going backwards into the lungs, okay? Did you guys do all 4, or did I hurry you?
I did not.
Okay, so take some time. We'll finish up. Finish up the 4. Sorry, I forgot that there was 4. Question?
Yes.
Yes, ma'am. Talk to me.
So for the other causes for the cardiogenic shock,
Yeah?
be also your like mitral stenosis or
Totally, absolutely. But is that that can be considered like coronary in nature because it's actual the heart. But yes, 100%, yes. So your mitral valve blew up. It's not working anymore. Absolutely, you can have cardiogenic shock. 100%.
and also for the recorded infection?
Yes, 100%. Yep, absolutely. Yeah, we'll do these and then we'll take a break. Did everyone sign up? Sign in? Sign up, sign in?
I was worried about the reviews.
I did the first day. I unironically did the first day.
The signatures are legible this time, yes? Hopefully.
I could say yes.
Okay, good. Thank you for checking. I appreciate that.
I'm like,
Because the scribbles last time.
do I have to pull my, can I just do Travis?
Yeah, no, friend, I know who you are, so.
Okay, so
You're-
it's fine.
Yes, 100%. I know, I know. Bueno, thank you so much. Okay, you guys, you ready? Let's continue on here. Continue on. Okay. You're oh gosh. Ugh. Okay. You're assessing your patient with cardiogenic shock. What signs and symptoms do you expect to find in this condition? Okay. So we're select all, SATA. I'm on like the SATA situation here, okay? So warm flesh skin, no, it's gonna be the opposite, right? Cool, clammy, maybe diaphoretic, okay? Prolonged cap refill, okay, right? We know we are in the cardiogenic shock, okay? Prolonged cap refill, the skin is the first organ to go, so we know that it's probably going to be a lot longer. Urine output greater than 30, absolutely not, okay? It's probably gonna be oliguric / heading towards the anuric world. Systolic blood pressure less than 90, yes. Why? Because we know that we're in shock, our blood pressure is down, okay? Crackles in lung fields. Crackles in lung fields, yes. That's one of the cardinal things to look at when you have someone in cardiogenic shock, okay? Dyspnea, yes, they're gonna have a hard time breathing, 100%. They're going to be short of breath. Decreased BUN and creatinine, no, it's gonna be the opposite, right? Increased BUN and creatinine. Strong peripheral pulses, probably not, right? It's probably going to be fast and thready, right? Why? Because we're probably more tachycardic or we're in some sort of arrhythmia. And then chest pain, yes, that's certainly a possibility, especially when we have a coronary cause as to why the pump is not working, okay? And we know that the patient is possibly having an MI, okay? Questions about this? These are important, you guys. These are important. The symptomology is important to be able to differentiate between the different shocks. You have to understand the symptomology, okay? Does that make sense? Okay, next one. A patient who has cardiogenic shock is experiencing labored breathing and low O2 levels. Chest x-ray is ordered. The x-ray shows, lo and behold, wow, pulmonary edema. See that we have a theme. The physician orders furosemide IV. What finding would require immediate nursing action? Okay, so we have 98 over 54. If you did the math, you'd figure out the math. It's probably fine, right? You have a systolic greater than 90. Urine output of 45, that's great, right? We love it. It's greater than 30, we're doing good. A potassium of 1.8, probably not so great, right? What could the patient be heading towards with hypokalemia? Hypokalemia, what are they at risk for? What? Sure, death, yep, that's the worst, but what else?
ST depression.
Okay, sure, okay, what else? What other arrhythmias might you run into with hypokalemia? Anybody remember? Okay, so your T wave might be probably inverted, that could be it. Okay, what else? Alex said death. What would precede death? VFib. So any sort of ventricular arrhythmia, okay? VTAC or VFib. people with hypokalemia and also hyperkalemia are at risk for arrhythmias. You need to be scared. If you see 1.8, you need to be running to the Pyxis to get some potassium, okay? Now, you have a new physician, right? It's July, so you got some residents, and he's like, oh, I'll take care of the order for you. Yeah, absolutely. Your K is 1.8. Gosh, okay, let's, that's pretty low. I'm gonna order 20 of a Cager, you know, the pill, the horse pills. Have you guys seen those? They're like huge. They're like 5 times the size of my finger. I'm gonna order 20. What do you think about that?
Give me a
No.
Also, I need IV.
Okay, perfect. So again, is a 1.8, is that an appropriate level to be giving PO where it's gonna take some time for that to be absorbed? Absolutely not, okay? Absolutely not. You need IV, okay? And then what would you guess? How many milli equivalents do you think? So it comes in 20s. Well, actually 10. 10 if you have peripheral, 20 if you have a central line. What do you think is gonna, just guess?
Basically 20 an hour until corrects itself.
Okay, so a couple times a 20. So oftentimes there's a protocol. This is too low for the protocol. You're calling the physician. I would say that the patient's gonna need at least 80 to possibly 100 milli equivalents of potassium. Okay, and then do you want to, so you start to give the 20, right? Start to give the 20, and let's say that you have a central line. Yay for us, thank goodness. So we can give 20 at a time, okay? Because remember, I'm sure you've seen it in the clinical setting, right? Potassium is very irritating to the vein. It's a vesicant. Oftentimes people complain, it hurts, okay? So they're gonna be like, oh, my arm is hurting. Can you slow it down? Can you stop it? And you're like, oh my God, you're gonna die of VFib because your potassium's so low. We have to get it in, okay? So you have a central line and you're putting it in. When would you want to recheck? So it's 8 o'clock at night. You're like starting this. Are you gonna wait till 4 a.m.?
No.
When would you recheck?
As soon as it's done.
As soon as it's done, yes. Oftentimes, after the last infusion, you wait an hour. You wait an hour. But I would maybe recheck at that time, especially if it's taking several hours. So 20 per hour, so what is that, 4 hours? I would check to make sure we're making some progress, right? I know that I'm still infusing, but for gosh sakes, I hope that it's not lower. Okay, does that make sense? So again, why I'm talking about this, why I'm taking so much time, is make sure that when you do something, you're checking to make sure it worked. Whether that's a lab or an assessment, evaluate what you did, right? What's the point of doing something if you're not gonna check to see if it worked? So, no, you would not give the Lasix. You would replace the K because you don't want the potassium to be 1, right? Okay, perfect. Questions on this? Okay. The physician orders a dobutamine IV drip on a patient in cryogenic shock. After starting the IV drip, the nurse would make it a priority to monitor for what?
Worsening hypertension.
Worsening hypotension. Okay, so we've talked a lot about this, right? Dobutamine. Dobutamine is a positive inotrope. It's going to help the heart pump more effectively. But in order for it to do that, it also has vasodilating effects, right? It's going to vasodilate. So when someone is in shock, we best be careful with that because we don't want them to be 80/40 and now we've made them 70/30, right? So especially when someone is dry, when someone is hypovolemic, okay, when they're dehydrated, that can worsen the hypotension. Does that make sense? So that's why when you have someone in cardiogenic shock, you could need to fill the tank a little bit, slowly, slow fluid administration, and then you also could be starting this coupled with a vasopressor like norepinephrine. Okay, does that make sense? Questions about this? No? Okay. Let's take a break. So 10:37, come back in 10 minutes. 10:57. That's 10 minutes. Oh, sorry. 47, sorry.
I like the math that you use.
I'm sure everyone likes that, yeah. 47, guys, 40.